Good afternoon, and welcome once again to Samaritans Purse International Health Forum here in 2017. Today we're delighted to be co-hosting our webinar presentation with Christian Connections in International Health. So we welcome them and all our colleagues through CCIH. Today we hope that you engage in our very interesting conversation. I just want to remind you, to the right is your chat box, which I encourage you to utilize. You can use it during the presentation or at the end of our webinar. We'll have a time dedicated to Q&A, and you can utilize it at that time as well. So as we typically do, we would like to open up in a word of prayer, and I'm going to call on Beth Thompson to pray for us.
Let's pray. Let's pray. Lord, thank you for the opportunity to come together this morning and learn about this important topic. Pray for Julie, pray that you give her the wisdom and the words to say, and Lord, may you just enlighten us and teach us, help us pray, answer questions, and just be with us today. Amen.
Amen.
All right. Well, I am very delighted today to introduce our speaker. For the last 5.5 years, Julie Tanaka has worked as our Senior International Nutrition Advisor here at Samaritans Purse. She helps the field offices in a multitude of ways, including nutritional surveys, training, program design, proposal review, implementation, monitoring and evaluation, and serves a very critical role during emergency relief, such as our work in refugee camps. Julie graduated from the University of California at Berkeley, where she received her BA degree in development studies, and then subsequently attended Loma Linda University, where she received a master's in public health, as well as a master's in business administration. So Julie is extremely educated. Julie previously lived and worked in China and Haiti, and then thereafter she worked for a Christian mission agency, and then worked at World Vision before she has joined us here at Samaritans Purse. So not only is she well educated, she has much international experience. Julie is as nice as she is smart, having had the pleasure of working with her. So today, Julie Tanaka will be presenting breastfeeding in limited resource settings, what every physician should know. So at this point, Julie, I'll turn it over to you.
Hi, everybody. Delighted to be here with you, and I'm passionate about this topic of breastfeeding, so I'm excited to be able to share with you for the next hour or so. It's one of those low-hanging fruits in public health and in your clinical settings where you may work, because it's one of the easiest or one of the most cost-effective ways to prevent childhood mortality and morbidity. So thank you for giving me the opportunity to share with you today. I'd like to get started on the presentation. Thank you. Next slide, please. So undernutrition or malnutrition is associated with 45% of child deaths. What this means is that maybe on a death certificate, a child may have died from, say, acute respiratory infection, or from, I don't know, from malaria or some other thing that may be listed on the death certificate, but it's associated with malnutrition, because malnutrition both increases the susceptibility of a child getting an illness and increases the severity of it. So undernutrition is associated with 45% of child deaths, and over 2/3 of these deaths occur in the first year of life, which is one of the most vulnerable times of a child's life. And infants who do not breastfeed are 14 times more likely to die from diarrhea or respiratory infections than babies who are exclusively breastfed in the first 6 months. And so nutrition and breastfeeding are very intimately linked. I mean, breast milk is it's supposed to be 100% of a child's diet for the first 6 months, and around 50% of a child's nutrition from 6 to 12 months. From 12 to 24 months. Okay, next slide, Globally, around the world in 2012, 162 million children under 5 were estimated to be stunted, which means they were chronically malnourished. And almost 100 million had low weight for height, which means they were wasted or had acute malnutrition. And mostly this was a consequence of poor feeding, whether it's poor infant feeding and breastfeeding or poor complementary feeding from 6 to 24 months. And they've had repeated infections, which affects a child's ability to absorb nutrients. Almost 38% of infants 0 to 6 months are exclusively breastfed, and this is a very low number. A lot of times when we look at a context, a village, if we try to make sure that at least 80% of infants are breastfed, and if it's under 80%, it's an indicator of significance that we realize that we need to flag. So 38% is extremely low. And about 220,000 child lives could be saved every year with the promotion of optimal breastfeeding and appropriate complementary feeding and the provision of supplements in food insecure populations. And when I say complementary feeding, that's just the feeding of additional foods in addition to breast milk from 6 to 24 months. So infant and young child feeding, IYCF, it's a key area to improve child survival and promote healthy growth and development. This whole area of IYCF is a big area we work in Samaritans Perths, both in our rehabilitation programs for children who have acute malnutrition and for the programs we do to prevent children from getting acutely malnourished or chronically malnourished, because infant and young child feeding encompasses breastfeeding, encompasses complementary feeding, and so today we're going to talk about one element, one component of IYCF, the breastfeeding part of it, but there is this whole other section on complementary feeding that we can, that's for another time. But the first 2 years of a child's life are particularly important. It's a window, a key window of opportunity, as optimal nutrition during this period lowers morbidity and mortality and reduces the risk of chronic disease and fosters better development overall. The effects of chronic malnutrition can be lifelong. It can affect a child's cognitive development, their physical development, their future earning potential, and there's even statistics on how it affects a country's GDP. So the first 1,000 days approach is something that is a buzzword that's kind of popular right now, and it's talking about this key window of opportunity, and it covers a period when a woman is pregnant to when the up to the period when a child turns 2 years old. And the reason why this is a key window of opportunity is because the effects of chronic malnutrition and stunting are mostly irreversible beyond 2 years of age for a child. And so we have this window of opportunity to get a child healthy and nourished and on a good foundation for the rest of their life. Because after that, it's much harder and it takes much more work and costs a lot more to try to reverse the effects of malnutrition. Next slide. So some of the policy initiatives around breastfeeding are the International Code of Marketing of Breast Milk Substitutes. Some of you may have been around when the Nestle boycott was popular in 1977. And this was largely in response to aggressive marketing by Nestle and some other companies of formula in developing countries. And it produced a lot of adverse health effects on children. So this code of breast milk, marketing of breast milk substitutes kind of came about as a result of that and was initiated by the WHO. And it prevents things like aggressive marketing in developing countries, and it requires things like forbids kind of the promotion of breast milk substitutes. The labels need to be clearly labeled in the local language. Free samples are not allowed in hospitals. No advertising or promotion of formula. The marketing people for the formula companies aren't allowed to have contact with the mothers in the hospital. That kind of thing. And so this is kind of the policy that's referred to all over the world still today in emergency settings. You'll hear a lot of times like, oh, are they breaking the code? Are they breaking the code? Are they following the code? Are they adhering to the code? And what they mean is like you may see in some refugee camps kind of a general distribution of formula, and that's breaking of the code. Or you may see a formula being distributed with cute little babies on the label. That's breaking of the code. That's considered advertising. Or imported formula that has labels in English when it's a country that that speaks Arabic. So that's breaking of the code. A second major policy initiative around breastfeeding is the Baby-Friendly Hospital Initiative that came about in 1991, and we'll talk about this a little bit more later. For a hospital to have the official kind of label or certification that they are a baby-friendly hospital, they have to follow 10 steps, and then we'll go through that in a few minutes. Also, there's the Global Strategy for Infant and Young Child Feeding that WHO and UNICEF developed in 2002 to raise awareness about some of the main problems affecting IYCF and identify approaches and solutions and provide a framework of essential interventions. So these are some of the main policies around breastfeeding. Next slide. The current WHO recommendations around breastfeeding are: number one, early initiation of breastfeeding within 1 hour of birth. The second one is exclusive breastfeeding for the first 6 months of life. And number three, introduction of nutritionally adequate and safe complementary foods at 6 months, together with continued breastfeeding up to 2 years of age or beyond. So basically, early initiation within 1 hour, exclusive breastfeeding for 6 months, and continued breastfeeding for 2 years or beyond. Next slide. So I wanted to talk a little bit about the advantages of breastfeeding and the disadvantages of artificial feeding. And some of this is stuff that you may be able to maybe be able to pass on directly. Maybe you could think of this as almost like this section of the presentation, almost like a training of trainers, stuff that you could, you may be able to transfer to a woman in your clinic who comes in for a postpartum visit, or you help assist in giving birth, or maybe for prenatal checkup, or even a community member who you may be working with that you come across who just gave birth or who's in the breastfeeding stage. The next slide, please. Some of the key terms, there is a lot of jargon in nutrition, so I just wanted to clarify what some of these terms mean. Infant and young child feeding is that whole area of breastfeeding and complementary feeding, and it covers from 0 to 24 months. Exclusive breastfeeding, a lot of people, even in the States, misunderstand this term. Exclusive breastfeeding just means feeding a baby only breast milk for the first 6 months. So no water, no soups, no other foods, no formula. Continued breastfeeding, it refers to the recommendation to continue breastfeeding for 2 years. 6 to 24 months, it's recommended to breastfeed, but that's not considered exclusive breastfeeding because you're feeding a baby food by that point. Complementary feeding is the feeding of food to a baby from 6 to 24 months. Early initiation of breastfeeding is that period right when the baby is born, and the recommendation is to start right away within an hour. Mixed feeding refers to when you're feeding a baby, breastfeeding a baby, but also giving them formula or milk or water or other foods. Breast milk substitutes is kind of the technical term for a formula, or even cow's or goat's milk in some contexts. Prelactal feeds are the foods given to babies kind of before, like in the first few days after a baby is born, before a woman's mature milk comes in. A lot of times in a lot of cultures, they consider the first milk a woman has, which is colostrum, to be unclean, and so they give other prelactal feeds instead. Next slide, please. So there are so many advantages of breastfeeding, and breast milk contains the perfect nutrients for what a baby needs, and a lot of it has a perfect amount of lactose and proteins and fat that is easily digested for a baby and efficiently used. I mean, you can even tell from the amount, the wet diapers from a baby. A breastfed baby will have a lot fewer and fewer in volume of bowel movements oftentimes than one who is formula fed, because it's more efficiently used when they're breastfeeding. And it also protects against infection with the amount of antibodies in breast milk. It really protects a baby against different illnesses. It helps bonding and development between a mother and a baby, helps delay a new pregnancy, and it protects mother's health. We'll go into this a little bit more later. And one of the biggest benefits oftentimes for women is that it costs less than artificial feeding, than buying formula. And it costs less because you're paying less hospital bills oftentimes for when a child gets sick. Next slide, please. Here's a summary of the differences between human milk, animal milk, and formula. Oftentimes there's bacterial contaminants in animal milk and formula, especially when unclean water is used or bottles and nipples aren't sanitized correctly. There's anti-infective factors in human milk that aren't present in animal milk or formula, the antibodies we talked about. There's growth factors in human milk that aren't present in animal milk or formula. The protein is the correct amount and easy to digest in human milk. And there's enough essential fatty acids and lipase to help in digestion for human milk, whereas animal milk and formula kind of lacks essential fatty acids and don't contain lipase. For iron, there's a small amount in human milk and it's well absorbed. Animal milk and formula, they have, animal milk is not as well absorbed, and in formula extra is added, but it's not as well absorbed. For the vitamins, there's enough in human milk. For animal milk, there's not enough A and C, and formula, they add it. And water, there's enough in human milk, and animal milk extra is usually needed, and in formula may need extra depending on how they mix it up. Next slide. So the differences in the quality of proteins in different milks, there's a lot more anti-infective proteins in human milk. And you can see even the difference in the curds and the casein, and which makes human milk easier to digest and cow's milk more difficult to digest for babies. Next slide. Protection against infection, and it really is kind of a God's miracle the way he designed breast milk for the baby's health and for the even if a mother is sick and she's infected with some kind of illness. Her body makes white cells and antibodies to protect the mother, which the white cells go to the breast and make antibodies there, which protect the baby, because these antibodies are secreted in the breast milk to protect that baby from the specific illness that the mother is infected with. Because a lot of times in places, a mom will think she can't breastfeed because she's sick, but it's actually even more important during those times to breastfeed. Next slide, please. So we talked a little bit about colostrum. Colostrum is that first milk that comes in. Often it can be anywhere from 2 to 7 days, where when the baby's first born, that a mother has colostrum before her mature milk comes in. So the colostrum has a different kind of nutrient profile than the mature milk. The first bar shows kind of the fat, protein, lactose profile of colostrum, which is exactly what a baby needs during that time. For the second and third bars, that's foremilk and hind milk, and you can kind of see that hind milk contains more fat, and it's even so the foremilk is the milk that comes out in the beginning of a breastfeeding session. The hind milk is towards the end of a breastfeeding session. So that's why we also encourage women to empty out the breast so that the baby gets the milk that's full of fat towards the end of the feeding. So colostrum is Antibody rich, it protects against allergies and infections. It has many white cells, which protect against infection. It's purgative, which means it clears the meconium, and it helps to prevent jaundice. And it has growth factors, which help the intestine to mature, prevents allergies and intolerance. It's rich in vitamin A, and it reduces the severity of infection. And this is all important because there are so many cultures all around the world that think colostrum is unclean or dirty and give prelacteal feeds instead. Or they think the colostrum is not enough for the baby. And so it's helpful to know that how small a baby's stomach is when they're first born. It's the size of a cherry at first, or even like a marble, and then like a size of a walnut on day 3, and even on day 7 it's like the size of an egg. So the baby doesn't need a lot, and the colostrum is enough, and it's rich in antibodies and growth factors and vitamins. And so one of the reason why it's important also to teach on the importance of colostrum is when you do prelacteal feeds instead of colostrum in the beginning, it disrupts the healthy start of a woman developing a good supply of breast milk, and having a good start is crucial in developing a longer term breastfeeding, good healthy breastfeeding relationship. So if you're not feeding the baby colostrum, oftentimes your supply, a woman's breast milk supply kind of suffers, because it works on a supply and demand kind of thing, where the more the baby demands, the more the woman will supply, or the more her supply will increase. Next slide. So in the American Academy of Pediatrics, they recommend breastfeeding until 1 year and beyond. The WHO recommends 2 years and beyond. And the breast milk is important in the 2nd year of life. You can see from this graph that it's an important source of energy and nutrients, even in the 2nd year, and it can provide half or more of a child's energy needs, and between the ages of it can provide half energy needs between 6 to 12 months, and a little bit less than half from 12 to 24 months. About 1/3 between 12 to 24 months. You can see that it's not enough just to breastfeed. I mean, there's a big gap in iron, but it does provide quite a bit in energy, protein, and vitamin A for the baby's 2nd year of life. Next slide, please. Here's a graph that shows the risk of diarrhea by feeding method. It was a study done in the Philippines for infants from 0 to 2 months. You could see that the risk was pretty low when the child was fed breast milk only, less than 1% for 1% for babies fed breast milk and non-nutritious liquids like water or soup. 3.2% were at risk for diarrhea. Breast milk and nutritious supplements, babies who were fed those had 13.3%. And babies who weren't fed any breast milk had a 17.3% risk of diarrhea. Next slide, please. There are also many psychological benefits to breastfeeding. There's the emotional bonding that happens, also because the hormone oxytocin is released in the mother while she's breastfeeding, and it helps to form a close, loving relationship between the mother and the baby. That also helps with helping the mother become more emotionally satisfied. Mother also often responds to the babies in a more affectionate manner because of this bonding, and the babies often cry less as well because the mother is quick to respond to the baby's cries, and it's easier in some ways to just kind of offer the breast when the baby is crying in that way. Children also perform better on intelligence tests. Studies have been done on babies who have been breastfed. So next slide, please. The lactational amenorrhea method it also prevents, it helps with birth spacing. And so the recommendation is that women wait 24 months before they get pregnant again for birth spacing. And if a woman meets these 3 criteria, her menstrual periods have not resumed, she's breastfeeding on demand, meaning frequently day and night, and if the baby is under 6 months old. This method is supposed to be 98 to 99% foolproof. So if 100 women use LAM during the first 6 months, maybe 1 or at most 2 will become pregnant. So it's a pretty good contraceptive method based on natural fertility. And in a lot of these areas where a lot of women may not have access to contraception, these natural methods are key. And also for birth spacing, mothers are less, when they have that 24-month period in between their births, they're less likely to die in childbirth. The mothers are less likely to miscarry. The newborns are less likely to die, be underweight, or born early. And the babies usually grow up bigger, stronger, healthier. And the older children are more likely to grow up healthy and strong. Next slide, please. For the disadvantages of artificial fertility, one of the biggest things is in developing countries, formula must be mixed with water. Even if you're using goat and cow's milk, it often is mixed with water as well. And water is often polluted in developing countries. Women may not be aware of the sanitation methods needed in the preparation of bottles and nipples and in water. And even if they are aware, they might not always have the means to perform what's necessary to keep the water clean and the bottles and nipples clean. They need, first of all, fuel to boil the water, which may not be easy to get. It may not be easy to get wood and other kind of fuel. And then they might not have electricity and light to be able to do the sterilization at night. And thirdly, a lot of times women use less formula powder to make the container last longer. And so babies are getting inadequate nutrition as women try to, they dilute the formula. And it also interferes with bonding. A lot of times babies have more diarrhea and persistent diarrhea, more frequent respiratory infections, more likely to become malnourished and vitamin A deficient. And the malnutrition happens especially when the babies have persistent diarrhea. There's more cases of allergy and milk intolerance. It's an increased risk of some chronic diseases, increased risk of obesity. Studies have shown lower scores on intelligence tests. The mother may become pregnant sooner. And for the woman, there is an increased risk of anemia, ovarian cancer, and breast cancer in the mother. Next slide, please. So how breastfeeding works, next slide, is that in an anatomy of a breast, there's the muscle cells, milk secreting cells, there's the milk ducts, the larger ducts, the nipple, the areola, Montgomery glands, the alveoli, the supporting tissue and fat. And the oxytocin helps make the muscle cells contract to secrete the milk. And the prolactin hormone helps these milk secreting cells in the production of breast milk. Next slide. So prolactin is secreted during and after a feed to help produce the next feed. So it's a hormone that works to help in the production of breast milk, and it's in the blood. So sensory impulses from the nipples, and with the baby suckling, it releases this and helps with the production of breast milk. And it's usually secreted more at night, and it also helps suppress ovulation. Next slide, please. The oxytocin reflex, it works before or during a feed to make the milk flow. So again, it's in the blood, and because of the sensory impulses from the nipples and the baby suckling, it helps for the letdown reflex or the secretion of breast milk, where we saw earlier, it helps the muscles, the muscle cells around the milk secreting cells to contract to release the milk. And also right after birth, this hormone helps make the uterus contract and helps prevent postpartum hemorrhaging. Next slide, please. So helping and hindering of the oxytocin reflex, what helps a mother secrete the milk and what helps her in breastfeeding is to think lovingly of the baby, to hear the sounds of the baby, to see the baby, to touch the baby, and confidence. So even looking at a picture of her baby or even hearing the sound of another baby sometimes causes women to for their breast milk to flow. So it's but what hinders is often worry, stress, pain, and doubt. And so often the role of a healthcare provider, of a doctor, nurse, a lactation consultant, or a community health worker is to help the woman gain confidence that she can breastfeed. She has what it takes. She's doing a good job, and just to be a cheerleader, because so much of breastfeeding is that confidence. And as you can see here, a lot of this affects her oxytocin reflex. Next slide. So an inhibitor in breast milk is when the breast is too full. It inhibits the breast milk from being produced. And this is useful, of course, when you're trying to wean, or if a child passes away, you don't want to be producing breast milk forever. But this also indicates how the supply and demand mechanism works. If a baby is not removing breast milk from the breast, then the breast is not producing breast milk. And so for a healthy supply to be developed from the start, a baby needs to be removing breast milk on a regular basis, or a woman needs to be expressing breast milk, either with her hands or a pump, for milk production to be at a healthy level for the baby's needs. Next slide. So this is just one of the like flip charts we use in some of our community health programs that illustrates feeding on demand. And this is why it's feeding on demand is important, to remove breast milk from the breast on a regular basis so that a woman can keep up her supply. And it sort of just illustrates, you know, do it constantly in the day, constantly at the night, in the evening, and at the nighttime, and often every 2 to 3 hours is ideal, especially when a baby is born. Next slide, please. For a baby, for breastfeeding, one of the most important things is attachment and positioning. And as a clinician, or as a nurse, or as a public health practitioner, this is you can observe a woman breastfeeding and help her with attaching and positioning. So next slide. As you see here, this is just a picture of a good proper attachment, where a lot of the areola is inside the baby's mouth and it's a deep attachment. Next slide. This is the difference is here on the right is kind of a shallow attachment, and on the left is a good attachment. And a lot of times, if a woman is new to breastfeeding, or especially a newborn's mouth is very small, it can often default into the right side without proper kind of training or help if a woman doesn't know what it's supposed to be like. A second picture. Second slide. So the outside appearance is the left is the good attachment, and the right is the poor attachment. And why is this important? Next slide. The results of a poor attachment can be pain and damage to nipples, and it can be fissures, there can be sore nipples, and it often can be very, very painful. And it can lead a woman to not want to continue, to want to give up. In addition, the breast milk is not removed effectively, oftentimes because a woman's breast gets engorged if a baby's not removing milk properly because of this attachment. That then leads to apparent poor milk supply, and then the baby's unsatisfied, wants to feed a lot. The baby's frustrated and refuses to suckle, and oftentimes in the end, because milk is not being removed adequately, the breasts make less milk and the baby fails to gain weight. Next, oftentimes the causes of poor attachment are the use of a bottle before breastfeeding is established, and maybe for later supplements. A mother may be inexperienced, and maybe her first baby, maybe she used to feed her babies bottles for her other children. It could be a functional difficulty, like the baby may be small or weak or premature. Maybe the breast is poorly protractile. There may be engorgement where the breast is too full and it's hard and it's difficult for the baby to attach. And maybe the woman had a late start because she was feeding the baby prelacteal feeds and not the colostrum. And also, maybe the woman doesn't have skilled support. It's maybe there's less traditional help and community support where she is from, and maybe the doctors and midwives and nurses are not trained to help. And so all of this can cause poor attachment. Next slide. So it's a baby has reflexes that make it easy so that once you attach properly, a baby can do the rest of the work. The skill the mother needs to learn is to position the baby and then properly, then the baby can learn to take the breast. And the baby has a rooting reflex where when something touches his or her lips, the baby's mouth opens, puts their tongue down and forward. They have a sucking reflex so that when something touches the palate, the baby sucks. And the swallowing reflex, when the milk fills, when the mouth is filled with milk, the baby swallows. So thank God we don't have to teach those three things. All we have to do is position the baby properly, and they usually pick up on the rest. The next slide. We're going to talk about positioning. This is another kind of a flip chart we use in our community health programs that shows the different types of positions. The top left, top middle, and bottom middle are the most commonly used positions when sitting up, and then the bottom left one is another one women can use when they're laying down. I mean, we don't often, it's not many women who have twins, so the ones on the right can be useful but aren't too common scenarios. Next slide. So the ones, two of the three I talked about as being the most common are where one is the baby is kind of under the arm, almost like across her side, which is the one on the left, and one where the baby is across a mother's body, like so the first one, a mother's holding her baby in the underarm position. It's useful for twins. It's useful for blocked ducts, milk ducts, and it's useful for babies who have difficulty attaching. The one on the right is useful for very small babies and sick babies. And the one on the right is a common position. And if you just switch the arms where the woman is holding her breast with the other hand and holding the baby with the other hand, it's a whole other position completely. Next slide, please. And this third one is the one where a baby's lying down. In like a clinic or community health program, sometimes pictures, or it's not always the easiest. I mean, you can use a doll to kind of demonstrate, or you can use pictures to kind of demonstrate to the women the different positions. So when I've done trainings on the field, I've used dolls, and even I've taught men to do this, to teach on this too. So it's not just women that can teach on this. On Amazon, you can buy fake breasts under the Halloween costume section, and it's kind of useful, and it gives people a good laugh in my trainings as well. Next slide. So breastfeeding while sitting down, so in a clinic setting, a community setting, it's helpful during these visits to observe a breastfeeding. And what you can do is to keep in mind these 4 points and to check for these things as you observe a breastfeeding. Make sure the baby's head and body are in a straight line, and make sure his or her face faces the breast with his nose opposite the nipple, instead of kind of like the body facing outward and away from the body, where I'm not sure. It's a little bit hard when I can't demonstrate, but when the body is, a little bit farther away from the mother's body. Number 3, the mother should hold the body close to hers. And number 4, if her baby is newborn, she should support his bottom and not just the head and shoulders. So you can show her how to support her breast with her fingers, like her middle ring and pinky against the chest wall below her breast, and her first finger, like her pointer finger, supporting the breast, and her thumb above the breast. And her fingers shouldn't be too near the nipple, so that it's not preventing the duct with the milk flowing through the duct. Then explain or show her how to help the baby to touch by helping her or showing her or telling her, touching the baby's lip with the nipple and waiting till the baby's mouth is opened wide. That's key in having a good attachment, and moving her baby quickly onto the breast, aiming his or her lower lip below the nipple. And notice how she responds. Ask her how her baby's suckling feels. Oftentimes, if it's a bad attachment, it'll hurt a lot. And look for signs of good attachment. If the attachment is not good, try again. And those pictures I showed you are, yeah, help to know whether it's a good or not good attachment. So, so then for next slide, please. Next slide. So while you're in the clinic, since this is a presentation for clinicians, I wanted to talk about the Baby-Friendly Hospital Initiative, because if you do these 10 things, I mean, you could pretty much say that you're giving women the strongest chances of starting a good breastfeeding relationship as possible. The first one is have a written breastfeeding policy that is routinely communicated to all healthcare staff. The second one is train all your healthcare staff in the skills necessary to implement this policy. Number 3 is inform all the pregnant women about the benefits and management of breastfeeding. Number 4, help mothers initiate breastfeeding within 1 hour of birth. Number 5 is show mothers how to breastfeed and how to maintain lactation, even if they are separated from their infants. So which includes like how to express milk, how to pump milk, if a baby has health issues and need to be separated. Next slide. Give infants no food or drink other than breast milk unless medically indicated. 7, practice rooming in, which means allowing the mothers and infants to remain together 24 hours a day. Number 8, encourage breastfeeding on demand. 9, give no pacifiers or artificial nipples to breastfeeding infants. Number 10, foster the establishment of breastfeeding support groups and refer mothers to them on discharge from the hospital or birth center. So next slide. So how you can help a mother with an early breastfeed. Avoid hurry and noise and talk quietly and unhurried, even if you only have a few minutes. Ask the mother how she feels and how breastfeeding is going. Sometimes it's easy to just start off with information or suggestions, but it's good to kind of listen and empathize and hear how she feels. Observe a breastfeed. There's all kinds of checklists out there on what you can be looking for as you do an observation. Some of the things I just mentioned about attachment positioning, those are things you should be looking for while you observe. Yeah, if she's doing well, if the position and attachment are good, tell her how well she's doing. You may not necessarily need to show her what to do. She may know what to do. Give help with positioning if necessary. If she's having difficulty, you could give her appropriate help. Give her relevant information. Make sure she knows about demand feeding, about the signs that a baby gives to show he's ready to feed. Explain how her milk will come in after the first few days of colostrum. You could tell her about how small a baby's stomach is in the beginning, the size of a cherry, and day 3 a walnut, that kind of thing, to just, let her know that what she's giving her baby is enough in the first few days. And answer the mother's questions. She may have some questions she wants to ask, or that she's worried about something. You can explain simply and clearly what she needs to know. Next slide. Before she leaves a maternity facility, make sure she has some support at home. You may want to talk to family members about her needs, and arrange a postnatal check in the first week to observe a breastfeed, in addition to the routine check at 6 weeks. And make sure she knows how to contact a health worker who can help with breastfeeding if necessary. It could be a lactation consultant, community health worker, could be a nurse. And if there's a breastfeeding support group, you could refer her to that. Next slide. Okay, sources of help. Supportive family and friends are very important. In some communities, they may have some traditional ideas which do not support breastfeeding, but there are often places where they can find support even in those contexts amongst friends and relatives. An early postnatal check check within 1 week. It should include an observation of a breastfeed and a discussion of how the breastfeed's going. You can help mothers with difficulties before they become serious problems at that stage. The postnatal check at 6 weeks should also include an observation of a breastfeed. Continuing help from healthcare services. Anytime healthcare workers in contact with a mother and a child at under 2 years, she should support breastfeeding. And for community health workers, they're often in a good position to help breastfeeding mothers because they may live nearby, see the mother more often than a facility-based worker. So it's important to train them as well. And a breastfeeding support group, of course, is important. Next slide, please. So we talked about the oxytocin reflex and how important confidence is in that reflex. And so it's important to help a woman build confidence and give her support. So accept what she thinks and feels, even if she has a mistaken idea. If you disagree or criticize her, it may reduce her confidence. So there's ways of you can reflect back and respond and show active listening skills. And recognize what she's saying, even if it's a mistaken idea. I mean, in the later section, you could give her little relevant information that's correct. Because so many places where I go all over the world, one of the biggest barriers to women accessing healthcare is how she's treated by healthcare facility staff. And she feels like she's looked down upon or spoken harshly to. Even if it's correct information, that often can erode a woman's confidence. So recognize and praise her for what she's doing right. Give practical help. Give a little relevant information. Back to practical help. Sometimes a mother may feel tired or uncomfortable, maybe hungry. Maybe she's gotten a lot of advice already. Maybe what she really needs is you to help give her a warm drink or something to eat, or help get her clean and comfortable, or hold the baby while she gets comfortable. Sometimes that's what she needs. And for the little relevant information, tell her what's useful now, not necessarily bombard her with all this information she may need for the next 6 months. Maybe 1 or 2 pieces of information at a time, especially if she's tired. That's more useful. And wait until you've built her confidence by accepting what she says and praising what she's done right before you give her new information or correct a mistake. Using simple language is important. Even the term exclusive breastfeeding translated or in English can be too technical. That word exclusive can be confusing to someone. Or I don't know, infant child feeding, like all the key terms I listed, those are all a little bit too technical oftentimes for women. Just use simple language to illustrate the same thing. And tell and make 1 or 2 suggestions, not command them what to do. Next slide. So breastfeeding will mostly be successful if a mother feels good about herself, if the baby's well attached to the breast so that he or she can suckle effectively, if the baby's allowed to feed on demand or suckle as often as he or she wants to, and the environment supports breastfeeding. Next slide. Next slide. So I'm finishing up here with just this last topic about formative research. Depending on where you work, there's a lot of things about the external environment that can help or can hinder women from breastfeeding. So these are some important questions to ask about people in your communities. Who are the key influencers in the community? How do they affect a woman's decision to exclusively breastfeed or breastfeed in general? Are they included in your program, or are they included in the messaging that you're doing from your clinic? And what are some other barriers to exclusive breastfeeding? And what are some exclusive breastfeeding myths or beliefs? Next slide. Oftentimes in developing countries, these are some of the biggest barriers I've seen expressed in my travels and in my work. A woman's workload, oftentimes she has maybe 3 or 4 other kids that she has to take care of. She's walking 2 hours a day to get the water. She's having to do some of the farming. Often, all of these things make it difficult to exclusively breastfeed a newborn or to continue breastfeeding till 2 years. there's a lot of cultural beliefs oftentimes about children eating other foods. Maybe they think children will get dehydrated if they don't drink water in the beginning, or they may think that the colostrum is dirty and will make the baby have sicknesses or that kind of thing, or that the baby shouldn't or needs this kind of food before 6 months to develop a healthy body, just different things like that. Oftentimes there's lack of family support. Maternal depression interferes with breastfeeding. Lack of knowledge about the importance of exclusive breastfeeding. Self-efficacy. In a lot of places, women think I don't have enough breast milk, or I don't have what it takes. And this is where that lack of confidence comes in, and our role can be to help show them that they can, and with the right positioning and the right information, the right practice, they are able to do it. And sometimes, lastly, it's the marketing of formula companies, which is why that code is so important. To limit just a general widespread advertising of formula above breastfeeding. So that next slide, that's all I have for my presentation. I know that was a lot of information, but I'm open to questions and answers now. I think Lance or Beth will.
Yes, Julie, that was, let me just start by saying that was really just a phenomenal presentation, very clearly presented and yet so informative. From a physiological and emotional perspective, breast milk really is God's miracle food for babies, and you presented that very, very well. Julie, Belinda has a question to kick things off. She says, how does the underarm position help with blocked ducts?
We've lost Julie momentarily.
Okay.
We'll come back to you.
All right. Okay, we're having a slight technical challenge here. We've lost Julie just for the moment. Just remind you, as we're working to bring her back to us, just encourage you to reach out and utilize that chat box there on the right. And we do have a few more questions coming in. Skip says, thanks for this presentation. Do you see any role for speech language pathologists in helping providing education and training for the babies who have trouble with feeding and swallowing? So thank you for that question, Skip. I'm going to continue to wait for Julie, as she is our subject matter expert with these questions. And we're still awaiting her arrival. But in the meantime, I am going to just make a few quick advertisements. First of all, I just want to remind you all that CME is available for this presentation. If you'll recall the email you received, it provides a form and instructions that you can submit to receive 1 hour of CME credit. So I certainly encourage you to do that. Also, just to let you know, we are working on providing CME for recordings that you can access through our website at health.samaritans.org. So many of you all have inquired about that, and we are working on that so that you can just at your leisure watch our recordings and obtain CME credit. So that's some things we're working on. Also, just want to remind you, next month, February the 8th, our next presenter will be Dr. Burton Lee, who will be presenting an update on sepsis, new sepsis 3 guidelines. He was with us about a year and a half ago and presented, and so he'll be doing an update on February the 8th at 12 noon Eastern Standard Time. So with that, Julie, I believe we have you back in the room with us here.
Sorry about that.
Oh, no problem. We believe we got it rectified here. So I've got about 3 questions for you. The first question is from Belinda, and she says, how does the underarm position help with the blocked ducts?
Well, I guess a lot of times, the more standard kind of method is the one across the body. And when a woman has a blocked duct, often a lot of times it can be like on the side or in a position, in a place that's not being emptied out from her regular position. Like a lot of times also a woman's like a bra can kind of block the duct. And so oftentimes it's like on the side, and so that underarm position kind of gets the baby on that side of the body a little bit more to release the duct from that side. I mean, there can be different reasons for a blocked duct, like even a woman sleeping on her breasts or an underwire in a bra or a really tight clothing, and so that kind of helps in a lot of cases where the duct might be blocked on the side.
Okay, thank you. Julie, Skip poses the next question. He says, do you see any role for speech pathologists in helping or providing education and training for the babies who have trouble with feeding and swallowing?
Speech pathologists for feeding and swallowing. I'm not actually too sure the role of speech pathologist. That's a good question. I mean, I know that like a baby who has a short frenulum oftentimes can get, like that little piece of skin under the tongue can get it like cut a little bit, and that helps with breastfeeding. Sorry, but I'm not exactly sure the role of a speech pathologist in at that stage of breastfeeding.
Yeah, that's an excellent question. Honestly, Julie, I'm not sure either. We will maybe we will look into that, research that, and see what we can do to answer that question. Yeah, I know speech pathologists do provide input certainly for young children, certainly that have had cleft lip and palate repairs and problems. So it wouldn't surprise me if they do have training to serve in that role, but I couldn't say specifically. But Skip, thank you for that question.
Thank you.
Next, it says, Julie, everybody's thanking you, and they say, Mona says, do clinicians, clinics, and hospitals provide potable water to breastfeeding women to better maintain milk supply?
Like for her to drink herself?
I believe that's what she's saying, yes.
So she's asking, like, should they or do they?
Do they? I think she's saying, like in a developing world setting, do some of these programs provide clean potable water and water resources for the mother so that she can, have adequate breast milk for her child? I believe that's what Mona's asking.
Okay. I mean, I think that would be ideal for a hospital to provide, I mean, not only just water, but food as well. But I know in a lot of cases, I guess depending on the country, they expect the woman's family to provide kind of the water and the food for the patient. So yeah, I think it kind of probably depends on the country. I mean, ideally, like it would be provided to the women.
Right. Yeah, I think I can say when we have multi-sectorial responses, like in a refugee camp, we certainly do that, Mona. But Julie's correct. It really depends on the venue, which country we're in. But that would be ideal for us to do that. Yeah. Julie, and go
sorry,
ahead.
I was also thinking of kind of like Ministry of Health hospitals, but for SP ones, I'm glad you spoke into that, Lance, because.
All right, thank you. And then Julie, your colleague Cindy says also, thank you for this excellent presentation. Can you add any commentary about how kangaroo mother care might support exclusive breastfeeding?
Oh, yes. Kangaroo mother care definitely does establish a really close relationship because you're keeping the baby on the mother. like with a bare chest for the mom, and probably just like a diaper for the baby. So because the baby is in such close proximity to the mother is able to pick up on the baby's cues very easily for when the baby might be hungry. And yeah, so I mean, it's ideal and it's great because a mom can tell right away, maybe when a baby's crying or when they're rooting towards the breasts, that the baby needs to feed. So that's an ideal situation.
Okay, great. Thank you. For the sake of time, I'm going to conclude with this last question or statement from Paul. Oh, I'm sorry. Okay. Let's see. Belinda says, do you recommend using a hot compress and massage to breast prior to feeding again if there are blocked ducts?
Yes, yes. And that's a whole other section too on breastfeeding complications with mastitis or blocked ducts or engorgement and that kind of thing. But yes, warm compresses and massaging is very helpful for blocked ducts.
Excellent. Okay. All right. Well, thank you so much. So, okay, I believe this is it in conclusion then. Paul states, very helpful presentation. We're interested, and he refers to SIL lead. He says, in whether people have already worked on expressing this type of content in local languages. If so, they would love to hear about that. And he shares his email with us. So we will, Paul, we will see if we can't provide that information for you and send that out to you and to our listening audience. So, all right. Well, you all, excellent questions. And again, Julie, back to you. Phenomenal presentation. Delighted to have you as our colleague here at Samaritans Purse to present here at the forum. As I mentioned, next month on February the 8th, Dr. Burton Lee will be providing a subsequent webinar, an update on sepsis, new sepsis 3 guidelines. And with that, we would like to conclude today here at Samaritans Purse International Health Forum.